Hello, everyone who is watching us now. Welcome to this warm-up event. We call it warm-up as a pre-meeting for the Global Summit Telemedicine Digital Health, which is organized by the Medical Association of São Paulo. We're going to our 5th edition this year. And this warm-up is done in partnership with the International Society for Telemedicine and e-Health. And here we have specialists that are members from our society, and they are going to share with us today international experience in digital health. This meeting is a way to present knowledge, experience, and visions from our international speakers, so we can disseminate the knowledge and information regarding digital health and all its aspects. Today, I have the pleasure to have as panelists 4 wonderful specialists in this area. I'll just mention them, and then I'm going to introduce each one for their up to 15 minutes presentation. And in the end of our presentation, we are going to have Q&A session and discussions, and we hope you could stay with us till the end. This meeting is being recorded, and it will be made available afterwards, and we will inform you when it's going to be available and the address where you should go in the internet to watch it again, or if you're not able to watch it completely, then you also can share with your colleagues and friends. So I have the pleasure to have with us today Claudia Bartz, who is a registered nurse. She's an advocate for nursing, telehealth, and women in telehealth. Also, Natália Czajka. She is head of teleaudiology and screening department at the Institute of Physiology and Pathology of Hearings from Warsaw, Poland. She is replacing Professor Piotr Skarżyński, who are not able to join us today due to his professional commitments. We also have Professor Krishnan Ganapathy, who is a distinguished visiting professor from Kanpur, and he was past president of the Telemedicine Society in India. And finally, Professor Georgi Chaltikyan, who is a professor and head of digital health on Dagendorf Institute of Technology from Germany. So let's start straightforward with Natália Czajka. Please, Natália, you can add more information regarding your profession, and also of the topic that you are going to show us today. Natalia, the screen is yours.
Thank you very much. At the first, I will share my presentation.
While she's sharing, just to remind you, if you want to listen in Portuguese, you can go to the interpretation icon. There is a globe there. So we have a translation to Portuguese as well. And please think of questions you would like to ask for our panelists in the end of the session.
Okay, so can you see my presentation?
Yes, you just need to go to full presentation mode.
I make the full mode, so I
try. Right.
But you can see the full mode, yes?
Yep, you can see it.
I do it again, okay. It's okay?
It's coming. Just let's have a look at it. I think if you could start again, because you're not seeing it yet.
Of course.
Now we can see it. not in full mode, but
Okay.
we can see it.
Okay. And now?
Yeah, we can see it, not in full mode, but anyway, we can see it.
But it will be okay because I see the full mode and I don't know what to do now.
Okay, no problem. We can see your presentation.
It will be okay, yes?
Yeah, yes.
Okay. So go back to the presentation. Okay. Ladies and gentlemen, I'm pleased to present a topic regarding telemedical possibilities in different hearing disorders. I will present a method combines the concept of telemedicine and rehabilitation, creating a telerehabilitation dedicated to patients with auditory processing disorders. But the first we need to separate these two processes, hearing and auditory processing disorder. Hearing is a sense which has a significant impact on child's development. Disorders connected with hearing can have impact in various forms and affect each area of life. Hearing disorders may concern peripheral auditory system as well as its part responsible for central processing. But the central auditory processing disorders refer to difficulties in processing auditory information at the level of central nervous system, and which is very important with the correct structure and work of peripheral part. Frequency of occurrence is about 2 to 5% of the population of school-age children, but as co-occurring difficulties, for example, ADHD, ADD, or SLI, the problem can be as serious as several dozen of percent. According to available recommendation, there are three main approaches in the treatment of patients with central auditory processing disorder. The first is transforming the environment of patient the transforming of the environment. The second is teaching the child many strategies to compensate their difficulties, but the basis is always use of auditory training aimed at specific deficit. The stimulation of polymodal sensory perception by Skarżycki is an innovative therapy which is appliance in various groups of disorders that coexist with auditory processing disorders. The developed therapeutic programs have been prepared for the following 6 groups of disorders: delayed speech development, articulation disorders, attention deficit, difficulties in reading and writing, voice disorders, and stutter. The SPPSS therapy consists of several stages. After performing through diagnostic, the therapist locates all the obtained data to the SPPSS panel. Then the therapist programs the SPPS set, which is afterward used by the patient in undergo the therapy. There are 2 forms of its implementation, stationary and remote. The SPPS panel is used to program therapy. It is available in the website address, so access to it is possible from any device as well as from any place when we can we use an internet. The SPPS set includes headphones for air and bone conduction with a built-in microphone, the SPPSS adapter that modified sounds used in therapy, and the iPad for multimedia and psychoeducational games. The set has been awarded with many awards by national and worldwide organizations. The therapy usually consists of 3 levels, each lasting from 5 to 15 days. Break between every level is about 4 to 6 weeks, and before each level, therapist makes auditory test to program next level of therapy session. Each day there are 3 therapy sessions that last 2 to 3 hours and consist of 3 parts. First is passive listening of specially modified sounds. The second is relaxation. And the last one, the third one, are multimedia and psychoeducational games and working with a microphone. The passive part does not require the active participation of the patient. It consists of listening to precise sound material. The middle are muscles, perceptual motor process, auditory attention, and lateralization are stimulated. During this part of the therapy, patient can play, for example, stack blocks, draw paint, or play board games. Development of the game in a child-friendly form consists in practicing various auditory, visual, coordination activities, and psychological training. Various human senses like hearing, sight, touch, balance, and proprioception, as well as cognitive and language processes, are involved in specially designed games. As I mentioned earlier, SPPSS can be implemented in two forms, the stationary and remote. And on this slide, you see the stationary version, and it is dedicated to medical and therapeutic facilities. More often, it is carried out in the form group activities. And children really have fun during it, not having the feeling that they have any difficulties or problems. Their positive attitude is very important in therapy, so it's really success for them. And the remote version, this is the clue, this is our telerehabilitation. This is the remote version, and can be this type of therapy can be implemented anywhere. Of course, usually it's at the patient's home. Parents do not have to come to the center for daily classes. The hours of therapy can be adjusted to the family daily schedule, and it's a very good solution, for example, for children with autism. The SPPS set is equipped with various type of locks, so the therapy in children's home is very safe. And during the remote form of therapy, the therapist is able to connect with SPPS set, help the patient if it is necessary, and verify the remote form of the therapy. We undertook the research of comparing therapy in the remote and stationary version. The material used to assess the effectiveness of SPPS-based therapy included the results of 100 patients who received remote version compared to results of 100 patients who performed therapy in the Institute of Physiology and Pathology of Hearing. And according to the diagnostic and rehabilitation scheme, all subjects in the study group had tests to evaluate auditory processing with the framework of the ongoing rehabilitation. And the following tests were performed to evaluate auditory processing before initiation of therapy and at the end. It was frequency pattern test, duration pattern test, and dichotic digit test. Statistical analysis of the results obtained, which shows that the therapy use resulted in a statistically significant improvement in all auditory functions studied. A treatment effect evaluation, this is the last column, study above 0.8 shows that the effect was very high in both versions. So the results confirmed the high effectiveness of the stimulation of polymodal sensory perception by Skarżyński both in stationary and remotely implemented form. The quality of telerehabilitation intervention was maintained at the same level and on the therapeutic work at the therapeutic center, which was confirmed by the results of the patients. Remote SPPSS therapy as an effective telerehabilitation method has become an effective form of supporting patients in their own homes. So telemedicine, including in this case, telerehabilitation can bring the same effect as stationary interaction and even bring additional benefits. So thank you very much.
Thank you, Natalia, for this very interesting presentation. You can stop sharing screen now. And it was very nice to see that you did, a comparison, use scientific methods to evaluate not only the benefit of the therapy, but the comparison between stationary and remote telerehabilitation. Wonderful. We will have questions for you. And
of course, thank you.
Yeah, thank you. So just to remind all the participants that you can pose your question in the Q&A icon. And also just to remind that if you want, you can hear this presentation in English or in Portuguese. Well, the next speaker I would like to invite is Professor Krishnan Ganapathy. And as I presented before, he was the past president of the Telemedicine Society of India. And Professor Ganapathy is going to tell us the experience of digital transformation in India. Professor Ganapathy, please add anything you like to your presentation and for your professional presentation, and the screen is yours.
Thank you, Professor Fernandes, and thank all of you. Obviously, a meeting on global summit cannot take place without the most populous country in the world, India, being represented. 900 seconds is too short a time, but nevertheless, I will try to see what is happening in India, particularly in the last few years. Before I go into digital health, I want to emphasize to an international audience that digital India is now the really taking place. As you can see in this slide, we have almost reached 1 billion smartphone users, what would have been unthinkable even a few years ago. The entire country has become digital. We now talk about broadband in rural areas. We talk about e-governance. We talk about manufacturing chips in India and electronic devices. The import of electronic devices is almost come to a stop. Unified payment interface, UPI transactions in the month of May reached a staggering $170 billion. That was what was digital transactions which took place in just 30 days. Obviously, it is the highest anywhere in the world. Today, as you can see in this slide, QR codes are what is being used even to affect transactions of 10 to 15 cents. That is what is used in the remotest parts of India, in the villages of India, whether it is selling vegetables or whether it is making donations to temples in the Himalayas. So this is what is happening. India is already preparing for a 6G. The government of India has set apart considerable funding. Committees have started, and we are very confident that India will be the leaders in 6G in a few years from now. With this background, let us see what is happening so far as digital health is concerned. I'm just giving you samples of some of the best hospitals in the country. Of course, we do realize that 1,400 million people do not have access to this all the time. But nevertheless, in the next 10 to 15 years, this is what is going to take place. Today, we talk of IoMT, Internet of Medical Things. You can see in the hospital system where I am associated with, for example, you have a medication intake tracking system. You have remote health monitoring, all done wirelessly. We talk of drug tracing. We have our RFID codes everywhere. We have RFD readers, RFD tags on equipments and so on and so forth. And this is how hospitals are run today. Now, the Apollo group of hospitals, like some of the other hospitals, have already started planning for what we call a digital hospital evolution. Here you can see, obviously, we require compliance, adherence, predictive analytics, prescriptive. That is what modern healthcare is all about. The disease management and medical devices, we have a command center where operation decision makings are done. We have integrated healthcare system. And what is amazing is we are no longer talking of diagnosis and treatment. Instead, we are talking of promoting health, the promoting wellness the E-way. keeping people healthy using digital methods. As you can see here, the clinicians of today are slowly getting over and are slowly becoming digitally equipped. We understand and accept that clinicians are the influencers, they are the disruptors, if you want to call them. And here you see personal health records, EMR, etc. The champion is not just the government, is not just regulatory agencies, but the clinician of the future. The clinician of the future will be using decision support analytics. He will be using custom treatment pathways. He will be using clinical decision support systems and so on. Of course, a clinician alone cannot be digitally influenced. The patient also simultaneously, we are looking at the patient and we are trying to show the patient that it is in the interest of the patient if they are digitally empowered. As you can see in this slide, we talk about healthy living custom pathways. We talk about loyalty programs. We try to make it more cost effective using modern digital technology. We are offering digital patient services. A hospital in your pocket, a doctor in your pocket, a laboratory in your pocket is actually happening in many parts of India. POCD, point of care diagnostics, where with a drop of capillary blood taken not even by a paramedic, but taken by one of the relatives of the patient or the patient himself, we are able to do almost 33 tests, including liver function tests, renal function tests, and so on. I'm going to give you a few practical illustrations of how digital technology has been used in the last couple of years. We run, the Apollo Telemedicine Department runs one of the world's largest remote technology-enabled remote tele-ophthalmology centers. We have 115 centers, all located in the rural part of a southern state called Andhra Pradesh in southern India. And you can see, as of yesterday, we have done 2.89 million patients. Multiply that by 2. 5.6 million eyes have been evaluated over a period of 5.5 years, just 293 weeks, by 35 ophthalmologists who are physically located 200 to 300 kilometers away. We do fundus examinations. More than 350,000 fundus examinations have been done remotely, and with a turnaround time of 20 minutes, a computer-generated, annotated color report is given to the patient free of cost. So far as the patient is concerned, the government pays for this and we execute it. One of the most populated states in India is called the Uttar Pradesh, with a population of 300 million people. Here again, we have telemedicine units. These dashboards are updated in real time. Right now, as I'm talking to you, the information is being uploaded, and you can see here how consultations completed are 782,455 teleconsultations have been completed by 34 doctors onboarded. We cover various specialties, super specialties, and so on. This is in the Himalayas, and to the best of my knowledge, this was the world's first 24/7 tele-emergency services at a height of 15,000 feet in the Himalayas. As you can see on the slides on the lower left-hand corner, during winter, the temperature is minus 25 degrees centigrade. And before we introduced telemedicine, it was impossible to provide healthcare for almost 5 months in a year. Today, as you can see on the top right-hand side, 1,391 emergencies have been attended to, including myocardial infarctions, pneumonia, and surgical emergencies as well. And we have seen a total of 29,000 patients in this remote, desolated area in the Himalayas. We believe in using technology, and I'm extremely happy that the World Economic Forum has chosen us to execute a project where, again, in a very remote part of India, bordering China, called Meghalaya, where the hilly terrain, we are now screening for 5 cancers, more than 200,000 population, using smart battery-operated, AI-powered handheld devices for screening on the ground. Most of these are FDA approved, and the images are transmitted in real time to my specialists, medical oncologists, surgical oncologists in the big cities, and we are able to do a very sophisticated tele-triage. This has been going on for the last 8 months. This is another project which we are just starting next month, and I think this is the most amazing project. Never in my wildest dreams would I have imagined that in my lifetime, I will be having access to a chest X-ray, 3.5 kilograms weight, which can be taken in a backpack, battery operated, totally mobile. Just like a camera, you focus the X-ray machine on the patient's chest, the pictures are transferred to a laptop, and through the internet, it is instantly transferred to my radiologist, who report it with a turnaround time of less than 60 to 90 seconds. In case the X-ray is suspicious, we have facilities in the remotest parts to do a sputum testing. We do a PCR, a World Health Organization approved test, totally indigenous, made by a startup company in India 5 years ago. We are actually able to extract the DNA from Mycobacterium tuberculosis, and with a 100% specificity and sensitivity, we are able to do a polymerase chain reaction, a PCR test, which confirms this patient has tuberculosis. This is just to tell you what is happening in the field of digital health. BIRAC is a Government of India company, a Government of India nominated company. I also happen to be associated with this as a member evaluating projects. And in the last 3 years, we have allotted $100 million to support 500 digital health projects. And many of them actually have come from the bench to the bedside, where the phase 3 clinical trials are over. And today we have reached the stage where we are not talking of import substitution. We are not talking of make in India, but we are talking of make in India for the world. And this is what is happening now. Smart pill dispensers, personal emergency system for senior citizens, a virtual reality simulator for acute cardiac life support, manufactured at 10% of the cost in Western countries. These are just a few examples. A hand-cranked defibrillator in the remotest part of India. We still do not have power, and here you have a hand-cranked defibrillator for sudden cardiac arrest, and the pictures are self-explanatory. You can see how all this, which were started as in the laboratory, have today become commercially available in India. Yet another example, I belong to the BC era. Having been trained in the 20th century, I am accustomed to culture sensitivity, waiting for 48 hours to get an antibiogram. Today, ladies and gentlemen, with imaging for 60 seconds, we have manufactured a device which shines multiple light sources from ultralight, ultraviolet, visible, infrared, near infrared, and captures a multispectral images within 60 seconds. The AI algorithm gives comprehensive information by studying the images, not only about wound infection, tissue oxygenation, but it can even identify with a 80% specificity at the moment whether it is Staphylococcus, Streptococcus, and so on. These are now undergoing clinical trials, and we are confident that in 2 to 3 years, this will become commercially available. 5G is now available in many of the big cities. Just like what you see a movie, Netflix, for example, today many of our paramedics have body cams and from which they're able to take photographs. We start treatment. We initiate thrombolysis for a potential myocardial infarction or for a neurological stroke at the house itself, or at least when the patient is loaded into the ambulance, because the opinion is given by super specialists who are in a command center in the big cities. So 5G enabled ambulances, there are probably about 100 of them, and I'm sure in the next year or two, these numbers are going to multiply tremendously. This is one of the recent additions, a fully portable hospital built entirely by what originally was a startup company aided by the Indian Air Force. And you can see here how a tablet using tablets, a tablet-based application is provided with every kit. The total weight for each of this is less than 750 kilograms, and in a natural disaster, during war, or a basic primary care can be set up and it can be converted to an operation theater. For most trauma surgery cases, in less than 60 minutes, it becomes operational. Of course, there is a solar generator, we have ultrasound, we have digital radiography, and so on and so forth. The most interesting thing is the cost is 15% of the cost in Western countries. Digital health is no longer something confined to clinicians. It's no longer the prerogative of healthcare provider. I'm particularly happy that the leading institutions of technology in India, the Indian Institute of Technology, the Indian Institute of Science, and so on, have already started medical sciences department. I am a neurosurgeon. I have no degree in engineering and technology, but yet I am on the faculty of the Indian Institute of Technology, Kanpur. Many of these IITs have started building hospitals, and in 2 to 3 years from now, engineering colleges in India will be giving degrees in medicine, bringing engineering to life. This is what the whole motto is about. I could go on and on, but I do understand that time is a constraint. So what is my take-home message? My take-home message is, if a solution in India is a solution for the whole world, if we are a developing country, we were known as a third world, we were known as the global south. Today, I would like to call India as an emerging economy, the fifth most powerful economy in the world. I am confident that in my lifetime, it will become the fourth, or who knows, even the third. What matters most is how you see yourself. India firmly subscribed to the belief that thou shalt digitally transform. If Moses were to come down to the earth, every one of the 10 commandments would be prefaced by the word, thou shalt digitally transform. Digital transformation of healthcare is not a function of technology. It is a function of behavioral modification. It is a function of acceptance by the beneficiary, by the end user, by the intermediary. I have always said that only if there is political will something progress, and this drive to make digital India and to transform healthcare with digital health is a drive coming from the very, very top, from the highest level, from the Prime Minister it is coming, and therefore most of the public in India are gradually accepting it. Thank you once again for this opportunity.
Thank you very much, Professor Ganapathy, for this wonderful presentation. It is impressive, the evolution in India of the digital health transformation, from all that you showed us, and the dimension of the dissemination of these solutions towards population care is really an example for other countries, many countries that are also called developing countries, or you can name it otherwise, huge countries, huge populations, huge needs, and lots of opportunities. But as you mentioned, you need political will, you need management competence, and you need people that knows how to doing it. Congratulations also for your long history in the field of digital health, of telemedicine. You are an example for all of us. I'm a neurologist. I've been following you over time, and I'm really, really proud to see what you have accomplished. So you probably are going to have lots of questions in the end of this presentation. Just to remind people, please send your questions through the Q&A icon in the bottom of Zoom. And also you can choose to, in the icon where is a globe, to listen in English ou em português. Por favor, se vocês quiserem escutar em português, no ícone global de um globo, podem escolher essa língua. So our next speaker is Professor Georgi Chaltikyan. I introduced him before, and Georgi is going to talk about building the digital health workforce, approach to digital health education and training, which is a very important aspect of digital health. Georgi, please add anything you like for contribution from you or for Deggendorf. The screen is yours, Georgi.
Thank you very much, Professor Fernandes. Jefferson, first of all, it's a pleasure and honor to be again at Global Summit. Thanks for the invite. Thank you to the audience, of course, who are following these warm-up international, and thank you to the wonderful co-panelists. It's indeed an honor to be surrounded by such superstars. My name is Georgi Chaltikyan. I'm professor and head of digital health masters at Deggendorf Institute of Technology in Germany, at the so-called European campus Rot-Tallinn, and my primary focus is digital health education and training, as well as building the workforce and empowering the both professional as well as non-professional communities in digital health. In that regard, I have been also doing some consultancy for the WHO Europe, and a few of my remarks in this presentation will actually be based on the contribution that we provided to the one of the most recent World Health Organization toolkits on digitalization of health information systems that is due to be published in 2024. So there we co-authored a chapter on workforce development and capacity building. I would like just to, to set the stage, to quickly go through 2-3 slides that we commonly include in our keynotes about the transforming landscape through telemedicine that began as early as, in fact, it was pioneered even longer, even about more than 100 years ago, but began essentially actively used in 1980s. Then 1990s came the concept of e-health, then 2000s, of course, mobile health, and nowadays we obviously are using this umbrella term digital health, focusing on smart devices, on Internet of Things, as Professor Ganapathy mentioned, big data, predictive analytics, AI, and eventually personalized medicine. And this is just to put all that graphically, how we imagine and recommend thinking about what is digital health as a multidisciplinary domain of knowledge and practice, which is based but not limited to the scientific disciplines of health and medical informatics, health telematics, and of course with some obviously interfaces with bioinformatics. And we consider digital health to be consisting of 8 subdomains, as we like to call them, that are listed on these slides, namely the digital health records and information systems, as well as the health information exchange. The second being telehealth, telemedicine, and virtual visits, personal health records, and patient portals, so remote care, basically, largely. The third one being all about mobile health, including the digital therapeutics, or as we call them here in Germany, DGAS. The next subdomain is everything about imaging and image analysis, then the augmented intervention and augmented visualization technologies such as extended reality, robotics, gaming, the subdomain of sensors, wearables, RPM, and ambient assisted living, health data analytics and AI, and eventually the digital biomarkers, omics, digital twins, and 10P healthcare. I'll come to it in a second. These 2 slides I can't help presenting or speaking a little bit about the perhaps 2 most important recent or current trends in digital generally, and in digital health as well. Of course, a little less than 1 year ago, in my opinion, we witnessed the revolutionary development, which we think will very significantly transform the landscape of artificial intelligence, as well as the specifically landscape of healthcare AI. And of course, I'm speaking about the launch or the entrance to global landscape of the most successful up to now, probably Gen AI or large language model, the ChatGPT. And here we can see actually that the developments in AI systems can no longer be considered even exponential. It's already, as we can see, vertical, the language and understanding, and here we can see the so-called zero benchmark, which is the level of human performance. According to one interesting piece published in The Guardian a few months ago, those are the factors that lead to the so-called combinatorial explosion, as the author John Norton noted. So we might be at the brink or already within the phase of rapid transformation and qualitative transformation, when those quantitative changes that have been accumulating in the past decades may suddenly result in this combinatorial explosion, including the factors like the availability of massive cloud computing power, the unimaginable quantities of data that are provided by the internet for training LLMs, the significant improvements in algorithms boosted by further developing neural networks, and as the author says, money provided by insanely profitable tech giants, with all due respect, obviously. And that all will, in our understanding, bring us closer to the future of digital health, which would be what I call the 10P healthcare. I know initially it was considered 3P or 4P healthcare, then some of colleagues call it 5P healthcare. The highest or the most I found in the literature actually was 6P. I permitted myself to further expand it to even 10 words, all starting in P, and this is what I refer to as 10P health. And each of these words starting in P, in my understanding and in my opinion, makes sense and makes important difference. Predictive, preventive, personalized, precision, participatory, pertinent, proactive, pervasive, permanent, and platform-based. And this, in my understanding, is all going to be evolving around the common platforms for collecting, analyzing in real time, obviously with the use of artificial intelligence, because the humans will no longer be able to analyze or make sense of all that data. Obviously, health and wellness data coming from sensor-based devices, the person-generated health data, from genetic data, from self-reporting of health information, from EHR and other provided data, from claims, from ambient data, from social activities, behavioral, emotions, and others. Now, all that revolutionary transformation will be absolutely impossible without skilled and competent workforce. And not only workforce, but the workforce is definitely is a vital component of a digital health ecosystems and of digital health systems. And with digital transformation of healthcare, the traditional roles of the health workforce will also need to be transformed. As an example, as previous speakers have shown, there's a lot that should be and can be and should be and will be performed remotely and online. So there will be a paradigm shift, and there are already some doctors that are essentially trying or thinking digital first or remote first as the first option. And this is what we essentially refer to as the culture change, culture transformation, which is important and which is the cornerstone of the so-called digital transformation of healthcare, because digitalization is still not enough. We're speaking about culture transformation, and the culture transformation which should be also supported by the commitment of the leadership and regulators and authorities and the public. The health workforce is thus positioned at the critical stage to enable the digital transformation. For countries that aim to digitalize their health systems, the health workforce at large face challenges such as the lack of knowledge, skills, and motivation to work with digital tools. And these challenges affect the attitudes of health workers, making it more difficult to adopt digital tools and innovation. A few years ago, HIMSS survey, annual HIMSS survey, that was based on the feedback from 537 e-health stakeholders revealed that one of the main challenges is the number of sufficiently skilled workforce, sufficiently skilled employees, as you can see it in this table. So what are these knowledge, skills and competencies groups that need to be brought to the workforce, and not only to the workforce, and about that I will tell about that in a minute, in order to support the digital transformation. Digital health is obviously a uniquely interdisciplinary domain of knowledge and practice. It is based on knowledge and scientific disciplines within the domains of medicine, health, healthcare sciences, within the domain of computer science and information science, as well as from the domain of business administration and management, to name just the three most important. And the scope of the so-called KSC mix, as we like to call it, the knowledge, skills and competencies mix, are including but not limited to medicine and healthcare delivery fundamentals, including healthcare research, computer science like databases, networks, software, as well as data and information management, the development, deployment and management of digital solutions per se, including health information systems, mobile health applications and digital therapeutics, telemedicine, telehealth, wearables, biomarkers, health data analytics and AI, and skills and knowledge that are necessary for evaluation of digital tools and systems with regard to their effectiveness, efficiency, data protection, regulation, and of course, ethics. So in our work for this chapter on developing digital health workforce and empowering these societies to embrace digital health transformation, we have gone ahead and defined the three user groups of the digital health system. This is based off of the previous work on e-health workforce development at the WHO some years ago, actually about 10 years ago already, where the authors of that previous compendium have already subdivided or defined two major roles and two major user groups within the workforce. Back then they still refer to it as e-health workforce. And group one being the health ICT workforce. And these are we refer to as DHIS professionals, or digital health information system professionals, including managers, administrators of digital health systems, strategic developers, information managers, informatics specialists, technical staff, data protection specialists, data specialists, ethics specialists, assistant staff, to name, but most important. Just the most important. Of course, there is also more roles, which obviously we were unable to present you on slides. The group two refers to health workforce, which means these are healthcare professionals, workers that are not themselves engaged in developing and maintaining the digital health systems, but are obviously the active users of the digital health systems. And those are basically all other health professionals, physicians, dentists, nurses, allied health workers, support staff, including the assistants, nursing assistants, and others. And then in line with the most recent paradigm and the development of our understanding, conceptualization of digital health, which is impossible without empowered citizen, we introduced it as a separate third user group, including the citizens, the patients, basically all of us, right? Families and informal caregivers. Then for each of the user group, we suggested and we defined 6 dimensions of development of that user group, how to evaluate and approach that development. Number 1, the description of the user group per se and their possible roles. Number 2, the required KSC mix of the user group. Once again, knowledge, skills, and competencies. Number 3, a checklist for the current state of play of that user group. Then, needs assessment for education, training, and development of the user group. The approach is to facilitate education, training, and development of the user group, basically the approaches to this workforce or population empowerment. And lastly, challenges, risks, and mitigation. On this slide, we will just demonstrate several types of different education and training offers that could be used in relation to each of the user group. So type 1 is most suitable for the user group 1, and this is, in our understanding, best achieved by formal degree-based education as bachelor, master, and even PhD programs in digital health. Type 2A is the integrated or built-in courses, in our understanding and in our opinion, and this is our vision, that there should be no medical or nursing or allied health curriculum starting now, not even now, yesterday, without built-in, embedded digital health courses, of course. 2B would be the standalone or add-on courses that should be designed and delivered to those who have earlier completed their medical education and training. And finally, type 3, relevant to the user group 3, are ad hoc and on-demand various education activities for the general population, including information portals, community-based trainings, in-app training, video-based training, gaming, patient education apps, awareness campaigns, and information dissemination. And of course, as we progress more into the era of extended reality-based trainings. My key messages here are on this slide. The digital transformation of health system will require significant workforce development efforts. Without building these competencies, building awareness, promoting adoption, promoting embracement of digital, that transformation will at least not be happening as fast as we would like it to, but most importantly, it will not be devoid of significant risk. So the primary goal of this education and development is not even to support the transformation. The tsunami is coming. It will be coming whether we want it or not. But the most important is to make that future arrive on us in a safe and efficient way. With wider introduction of this technology, we will be seeing the emergence of at least 2 roles in the workforce: the digital health professionals per se versus health professionals that are working digital. It is important in our understanding to define and recognize these roles to facilitate the digital transformation. The knowledge of the current state of these workforce requirements, education approaches, and risk and challenges are crucial in building this capacity. With the increasing impact of digital health, the citizen is becoming as a central partner, contributor, and eventually probably the driver of these 10P healthcare. And the strengthening of all these 3 user groups is a key prerequisite for transitioning to the digital health system. Lastly, in 2 words about what we actually do. It's our Master of Digital Health, the program that we established 8 years ago, which has become probably one of the successful education offers, degree offers in digital health. We're also doing quite significant, or attempting at least, to streamline and harmonize the developments of curricula and the development of approaches towards digital health education and training. And we would be most happy and honored to collaborate with other educators and institutions active in that. We also feature our series of digital health events. I hope, Jefferson, your audience would not mind, and you, of course, would not mind. I know you wouldn't, that we also present our digital health international series. Please check the website, the Digi Health Day. Our symposium is coming up soon before the Global Summit. So everybody is most welcome to attend, also online, and to hear from as well major, brilliant opinion leaders and top experts from around the world. On that, obrigado, and thank you very much once again, and thank you for listening.
Thank you very much, Georgi, for your wonderful presentation as well regarding the situation that we have now with this tremendous digital transformation and the needs of professionals and also citizens to be educated, trained, and it was nice this classification that you presented and the strategies of actions that could be done for these three different groups of two different groups of professionals and one towards citizens, which is very important. The digital literacy is one aspect that is coming very strongly in need to be developed. And also, I reinforce your invitation for people to participate in the Digital Health Day in 10th of November, which became a very important meeting globally for this field of digital health. So our last speakers, we start with a woman, and we're going to close with a woman. I'd like to call for her presentation, Claudia Bartz. She's going to talk about planning digital health research for a successful dissemination. Please, Claudia, the screen is yours.
Thank you, Jefferson. Now I think I'm not muted, and
yes, you can see. If you can go to full mode, that will be fine.
I'm trying.
Yeah, this one.
Interesting. Any suggestions? Should I just go ahead? I'm clicking on the full screen tab.
But it's not working.
No.
Yeah, I see.
Okay, I'll just start.
Okay, that's fine.
Okay. Thank you for this invitation. I really appreciate being able to participate in the warm-up again. And as Jefferson said, I am a nurse. I have been a nurse forever. Currently, I'm the chair of the Telenurse Midwife Working Group for ISFTEH. And if any nurses are listening or midwives, I encourage you to join. There's no charge for you, so that's always a good thing. And gosh, what presentations I'm following. They're very, very interesting. So I'm going to do a little bit different focus, and that would be successful digital research dissemination. Among other things, I review manuscripts for a variety of journals, and lately they've been coming fast and heavy. And I've learned a lot from reviewing these manuscripts, and I would like to share with you some ideas about doing research and disseminating your research. Let's see, how do I forward this? Oh, here we go. Oh, let me try this again. I'm going to try to give you tips for successful completion, presentation, and publication of your research. Just a review, most of you know this, some of you might be new researchers, so I would emphasize it for you. I call it the research cascade. You always have to prepare before you jump into your project. And some people, I think, start at the middle and then find that they can't do either the front or the back successfully. But preparation would include your idea or your question for research, your problem identification, the articulation of a purpose, and your sample and your setting. Those are the things that you need to consider before you ever start to do actual research. Then your actions would be the interventions that you've decided to use for your research and data collection, data analysis, and results. And then completion would be your discussion and your conclusion, and dissemination, presentation, or more than one presentation about your research and publications. I expect at the Digital Summit there will be a fair amount of research presented, so that will be an opportunity for you to see the process and see where you fit in all of that. So what about getting started with preparation? You must articulate your idea clearly. If you're vague on what it is you want to study, everything else will be vague too, and that's not a good thing. You want to be real clear. The purpose of my study, or my question is, what is this? Why is this? How is this? And then review appropriate literature. This is a big challenge because I remember in graduate school, the faculty would say, well, just do it, do enough literature. Well, what is enough? But it's very important for you to consider what literature you're looking for and using as your preparatory material for why you're going to do your research. Shouldn't be too much and it shouldn't be too little. And I put there, be careful of theories. It seems that some authors, some researchers feel they need to hang their research on a theory. And sometimes that works. And sometimes it's like an extra arm. It really isn't necessary. So think about it if you're considering basing your research on a particular theory, like theory. And then state the purpose of your study in one sentence. And this should really be the pivotal point before you start embarking on your research process. The purpose of my study is to evaluate, assess, compare, contrast, whatever. And that will give you a clue as to what kind of design you're going to use. And design is very important as well. Qualitative research is generally done when we don't know much about the topic. If there's hardly anything in the literature about in response to the question that you're asking, that would be qualitative. You would want to do interviews or maybe focus groups. Descriptive research is a little bit more formal. You have a little bit more information. Maybe a pilot study has been done that you'd want to carry on. But again, it's pretty open-ended. Quasi-experimental research is getting into the control of variables. And variables are important for you to consider. Which ones are you attempting to change with your interventions? And which ones do you need to control for? And if you think about it, a lot of healthcare research is with people, and trying to control all the variables surrounding people, whether they're subjects in your study or someone else, is a big challenge. And then experimental research, the randomized controlled trial, called the gold standard. Yes, it's a good thing to do. It's very difficult, again, especially if you're doing research with human subjects. So your design depends on, your design will give you the type of data that you have when it comes to analyzing your data. Then what will your sample be? Who will your sample be? Where will you go? Are you going to use patients? Are you going to use people in the community? Are you going to assess new technology? Like we have hundreds of apps coming at us for health in the healthcare environment. And there are a fair number of studies of just the app. Does it work? Is it reliable? Is it valid? And that's a legitimate study, but you need to know that's what you're doing if you decide that's what you want to do. And then the setting is also important. Where are you going to collect your data? If you're working with people, if you're in a hospital, that would be one thing. If you're in a community, that's another thing. If you're working with a laboratory, what laboratory will you use? Will you have access as a researcher, and so forth? So very important to consider before you start in the process. And what materials will you need for interventions? If you're doing descriptive study, do you need tape recorders or audio recorders? Shouldn't even see tape recorders anymore, I suppose, but or will you need paper if you're doing surveys or questionnaires? What will you need for your study? Again, before you start your study, these are things that you need to answer for yourself. And then who will do the interventions? Will you collect all the data? Will others collect data with you? How will you ensure that everyone's doing it the same? Again, control of variables. You want to have everything controlled as possible. So if you're using 4 or 5 data collectors, they all need to be trained to do the exact same thing. Otherwise, your study won't have the reliability and validity that you hope for. Here we take a little pause for ethics board approval, and ethics boards are called different things in different countries, I have learned, and they work differently too. But it's not up to you, the researcher, to decide the level of risk in your study. It's up to either the board or a designated member of the board who communicates with you. If you're doing survey, for example, you think, well, there's not much risk in that, and it's private, and it's I don't have to get ethics approval. That's just wrong. So I would emphasize you need to find out what the rules are in your country, in your area. And if you use 2 sites, for example, if you're using 2 hospitals for data collection, then you might need 2 ethics boards approval. And this is a big challenge for people, but it's, I think, necessary to ensure the quality of your study. Okay, back to actions. Now you're doing your data collection. Did you give yourself enough time to collect data that you want for your study? And where will the data be stored? Again, it's about privacy and lowering the level of risk for your study. These are things that you need to be able to answer. And how will the data be processed? Will you have in vivo for qualitative interview data, or will you have access to data and analytics? Do you need the consultation with a statistician for analyzing your data? These are all important things to consider as you're getting ready to collect your data. And who will do the data analysis? Will you do that? And how far will you go? The kind of data you collect, whether it's nominal, like male, female, or ordinal, like a Likert survey, or more interval, like with a randomized controlled trial, all of that will impact how you analyze your data and how you report your data. What I find often is that people go way beyond the necessary when they're analyzing the data. For example, they might use statistical methods to analyze qualitative data, and that's really not necessary. And you need to talk with someone if you're not sure what to do in order to be using the right kind of analysis plan. And where will the data be stored? Who will have access? Again, was it stored for 5 years and then you discard it or burn it? Or do you need to store it at all? Again, digitally stored data, where will that be stored? Who has access? This is all important in terms of the risk surrounding your study. And how will the collected data be pulled together and formulated in results? Generally, in a manuscript especially, you want just the essential results. You don't need to know all the extraneous material about, if you're using people as subjects, you don't need to use a lot of extraneous material. You need to use what's appropriate and to display that in your publication and to use that in your presentation. And do the results answer the research question? There, we've got the loop completed where you had a good research question. The purpose of my research is to whatever. And do the results give you that comparison or that review or that analysis, or do they not? And either way, that's important. Those are important findings, because we should report no findings as well as statistically significant findings. Discussion and conclusion. Here's, when I'm reviewing papers, here's something that frustrates me. I read these long discussions after the research has been done, the data collected, the data presented in results format, then the discussion goes on and on and on about either what looks like should have been in the original part of the paper, building up a case for why you were going to do your research at all, or defending your findings, which is really not relevant. You just present your findings and there they are. You don't have to defend them with lots of extraneous material that we often find in discussion sections. And I gave some examples. If your problem for your research was lack of knowledge among people with heart disease, did the results of the education and training program that you used as an intervention help answer that problem? That's pretty straightforward. We don't need a lot of other material. I would say heart disease is widely researched. So the important thing there is to not use heart disease, which is pretty broad, but really be specific about the kind of heart problem or cardiovascular problem that you're focusing on, you're focusing your subject selection on, so that, again, we can see the reliability and validity of your findings. And then another example, if the purpose of your study was to see if adolescents would adopt learning methods to deal with their diabetes. Adolescents are a highly researched group, I'm finding, in various telehealth research. And did the interventions that you used show virtual learning could support adaptation? We know that adolescents are very much tech savvy, and it's logical to think that, well, a tech solution to educating them or helping them deal with their diabetes would be a good thing. And that's a real good research area to join in if those people are in your area of interest. Limitations, again, no need to go on and on and on. A few limitations, that should be it. For example, the research I do is with nurse-led telehealth research. And my biggest limitation is I only can read English. I can't read any other language. So I'm limited to English language papers. So that, I consider that a sort of ongoing limitation of my work. And then you get to the conclusion, and I say it should be short and to the point. Again, we don't need pages and pages of a rehash of your literature review and your discussion points. Just say, here's what we found. The next steps might include these types of research or those types of research. And I think one paragraph should be enough. I'm really a fan of short discussion section and short conclusion section. So for presentation and publication, presentations should summarize the whole study that you did, but with real emphasis on the interventions and your results. Sometimes presenters get so involved in leading up to their actual research that they run out of time before they present the real heart of the matter. So when you're thinking about the time that you have been given to present at a conference, you need to plan to get the really important things about your research in front of the audience. And when you're publishing, the title of the paper submitted should be short and to the point. I use short and to the point a lot, I guess. But I've talked with editors too, and my goodness, sometimes the titles are, 3 lines long at the top of the paper. It's like, really? So work on a short title. You can get the key information into a short title most of the time. I say that going back to that research cascade that I first used, that's a good way to organize your paper. So it flows in a predictable way and a fairly acceptable way in the research field today. And reviewers will look for the fit of the research parts. Was the purpose of your study answered in your research, for example? Did you use the right literature? Should you have used more or less? And did you use the right design and sample and setting? If you're saying you're doing a randomized controlled trial, but you don't control the subjects, intervention or non-intervention, you didn't do a randomized controlled trial. So they have to marry up and match. And then the analysis has to be correct for the type of data. If you have qualitative data, then you do content analysis. That's about what you do. You don't go into vast statistical analysis of qualitative data. And then appropriate discussion and conclusions. And you heard me say those, I think, should be, tight and short. And reviewers will also look for assumptions and elaborations that are not supported by the literature or by data. Again, I see whole big sentences or whole paragraphs from the in the research report in the manuscript that doesn't have anything really to do with either the purpose of the study or the process of the study. So be clear on what you're talking about and don't supplement it to make the paper longer or for some other reason. So in a nutshell, those would be my recommendations for doing research, presenting research, and publishing research. Publishing is not easy. I mean, maybe some people think it is in the world, but I haven't met too many of them. And it takes some really serious concentration on what's the process, what have I done, what will I do, and here are my findings to contribute to our knowledge about healthcare and healthcare technology. So I provided my email there if you have any questions, or if you have questions today too, if there's time. But I thank you very much, and thank you for this opportunity to speak.
Thank you very much, Claudia, for your presentation, for your review of very important methodological aspects for publication and dissemination of the results of research that applies to several areas of knowledge, including digital health. Sorry. We now go for the Q&A session. Please, all participants, if you like to ask something, please do it. You can do it in Portuguese. Você pode fazer a pergunta em português, que eu traduzo sem problema. Please use the icon of Q&A. Use o ícone de perguntas e respostas, QIA. So Natália had to leave. She was on the clinic. She has to see a patient that has just arrived, and so she's also keen to reply to answers that will come out eventually for her, and we can forward this answer to the person that has done it. And so I'll start with some few questions. We have a few minutes for that. I'll start with Professor Ganapathy. Professor Ganapathy, all these developments has really faced several challenges. I can not only imagine, but I can also think some of them that you might happen in India. So please, if you could mention one or two of these challenges or barriers that you have to overcome, and also how you managed to overcome that. Because of course, it's very nice to know about the achievements, the success, but behind these achievements, success, there was a lot of sweat and challenges that you had to face. So please, if you could mention one or two of them and how to overcome. This is also a way to learn from your experience, from the experience of India, what we should not do or what we should do in a different way.
Thank you for that question. I started telemedicine, got interested in 1998. And as you can believe, 25 years ago, telemedicine was a dirty word and everybody looked and laughed contemptuously. 3 things I would like to recall. The fantastic progress made in the last 5 years. We need to give a lot of credit to a global CTO, as I call him, COVID-19. It is unfortunate the millions of deaths which occurred, but at the same time, COVID-19 made the government of India wake up, made all the state governments wake up, all the authorities wake up, and because we had no other alternative, there was no choice. Remote, I call it technology-enabled remote healthcare became a necessity. The COVID drastically transformed everything. I have always said that a few mad people like me and you, sir, and Dr. Georgi, if I include all of us, a few mad people like us cannot change a huge population. The global CTO, the COVID did it. That is one. Two, payment. I mean, a major problem which I had in 2000, 2005, 2010 was how does a doctor get compensated? At the end of the day, philanthropy can at the best start a project, it can never maintain it. Making profit is not a dirty word. You have to generate revenue if you want a project to be self-sustaining. I cannot go on to people and say, please give me money, which is what I did for the first 10 to 15 years. I was the only loss-making department in the entire Apollo group of hospitals, in all the departments put together. But then the leadership had confidence, had trust in me. And over the last 5 years, our income is just a little above our expenditure. We still are not the star performers so far as revenue generation is concerned. A major thing, which was the first 2 slides, I deliberately mentioned that, was digital payment. Today, by touching a screen, it is amazing that 370 million people in rural India have bank accounts today, something unheard of. In the last 3 years, all these people have got a digital ID. 99% of India's population have the Aadhaar card. And because of that, they're able to transfer money. So digital transaction, payment of money, smartphones, internet, wireless internet, availability of internet in suburban and rural India. So technical help. And as I said again in the beginning, it is a government push. We were all there, but we could only progress so far. But because of the government push, today we do public-private partnerships with several state governments. I showed you a few of them. So I think the government is the most important person, and that was what happened. And of course, I have no way of proving it. I have no scientific data, but something tells me, a gut feeling, that the average Indian brain is wired in a slightly different way. I tell this because 90-year-old women who are illiterate, who cannot sign, are digitally literate. They know how to use a smartphone. 90-year-old women living in rural India who cannot spell out the alphabets of the English language, they know exactly which icon to press and what. The third thing, of course, is our local people have been amazing. Smartphones in India are all not just from Google app. We don't just download from the universal Play Store. I'll give you a simple example. The diagnosis of tuberculosis in remote area. How do I tell an illiterate 70-year-old person, do you have cough? Do you have hemoptysis? Do you have evening rise of temperature? Have you lost weight? Etc. etc. Very, very simple. I have on my smartphone, on the tablet, with the ASHA. The ASHA is the entry-level person, not even a paramedic, a school dropout who has been trained for 6 months. She shows an icon with blood in the sputum, and then an audio file is just 50 KB. Is an audio file which is shown. And then I ask this illiterate woman, do you have cough? And then I point this out. So she does not understand the word cough, but she definitely knows what it is when I simulate a cough. I simulate blood in the sputum. I show a person having rigor, intense rigor, animation. So all this has been done to a remarkable method. So we are able to digitally communicate with people who have had no formal education. So I think these are all the things why India is totally transforming. And I am absolutely sure, unless some major tragedy happens in my lifetime, assuming I live for at least 10 more years, in my lifetime, I will be able to see digital health become incorporated into the core of the delivery of the health delivery care system. My role as an evangelist for 15 years is now being replaced, and now I am no longer need to evangelize to create awareness, but now most of us spend our method in trying to make it cost effective, revenue generating, and making a business model out of it. So far, we do not yet have a business model. Once we get an insurance, the other thing is insurance has picked up remarkably. 70% of India's population today have some sort of insurance coverage. And once insurance pays for teleconsultations, insurance companies are realizing that it is in their interest to promote wellness, make people healthy, to avoid a coronary bypass surgery for which they have to pay. So insurance companies today, which I think is a great achievement in India, have recognized reimbursement for teleconsultations.
Wonderful. Thank you very much, Professor Ganapathy, for your answer. Professor Georgi, we, both of us, all of us that are here in this panel, understand the needs of training, education, and for the workforce and for the citizens. But one challenge is this one: who teaches? And so we need to teach the teachers. How do you see this process? How do you think we could teach people for themselves become teachers? Let's think also about undergraduate students, in their curricula, medical curricula or other professionals. Are the teachers prepared for teaching digital health? And how do you think we could tackle this situation?
Yeah, thank you very much, Jefferson. A wonderful question indeed. We need to build the capacity of the teachers in order to then build the capacity of the learners. That is absolutely correct. And it is as important a challenge or a similar challenge compared to the wider digital health per se, right? Because in the former times, when there were even the demand for digital or demand for remote care has been significantly less, right? So the people like Professor Ganapathy, like yourself, like other early adopters or those evangelists, it's pretty much reminds me the history of development of medicine and healthcare per se, right? If let's say 200 years ago, the demand for care, it was possible to meet the demand for care with the use of, let's say, dozens or hundreds of enthusiasts and excellently, let's say, educated people who were essentially heroes. Then with the introduction or with the movement from this sporadic care to really what we have now, which is, I call it mass care or mass medicine, and hopefully not mass distraction medicine, let's say, even if it sometimes can be. So that required massively to build massively these the network, if you wish, right? And to be able, that is where the global community eventually needed to adopt some standards, right? Such as in evidence-based medicine, because we were no longer able to limit the care to a few people, few enthusiasts, the few heroes who were doing basically thinking were able to thinking off top of their head and pioneering things and developing. So we are speaking here of systemic changes, Jefferson. So the best answer to your question is that we need a system, and a system requires clear understanding by the stakeholders, right? And this is why we so significantly, so peacefully advocate for stakeholder engagement, for cross-stakeholder and nationwide and even international and global efforts directed at policy refinements, at strategy development, as well as building awareness, essentially, and advocating. Until we introduce it on a systemic level, we will be in the same situation of early adopters, early heroes, but it will not be systemic. Now, in order to have that system-wide, in my opinion, there must be, again, understanding of the decision makers and commitment, like Professor Ganapathy very said, also a key word, unless the top leadership, the very main decision maker, let's say Prime Minister Modi or the Chancellor Scholz, or before Chancellor Merkel and others, it must be the top decision maker. who has to push a little bit for adoption and implementation of this change. And then the commitment, when the commitment is there and dedication is there, the infrastructure development comes next. The financial finances come next, and you build a network. Jefferson, for example, our degree program, masters. What is it as if not TOT? It's basically, it is, we train the trainers, we train the leaders, those who should go teach, educate, raise awareness, advocate, and eventually develop a network of professionals in absolutely in the same manner as the health systems 100 years ago developed the networks of certified professionals that were able to bring medicine from arts that was available to just, you know, a few people in the entire nation, few very rich and very well-doing people, to science and business, which is now available to billions of people around the world. And another key word, very, very quick, that I mentioned is certification, Jefferson. This is why streamlining these efforts and getting together with educators, with policy developers, strategists, internationally and globally, to develop, for example, the common framework. How should this training be organized? How should these future leaders be trained? How should they go into the field, you know, to spread, to bring that knowledge? That is why we are also so much, we don't spare effort to advocate bringing together people, defining, harmonizing the strategies, harmonizing the approaches, harmonizing the curricula. Without that, it will not be happening fast. But hopefully we're coming there.
Dr.
Yes,
Fernandes,
please.
can I make
Yes.
an observation, please?
Yes, please, Professor Ganapathy.
This is to Dr. Georgi. I can't help but mention this. I have listened to so many talks on digital health. I've read quite a few papers on digital health. I myself have given several talks on digital health. But sir, your presentation in the last 20 minutes was absolutely fantastic. Every slide of yours had so much of meaning in it, and you have been able to convey in 900 seconds what I'm sure will take months and months and months for others to get this. You have double distilled, you have taken the essence. In India, we call it, you know, we have food, ready-made food, double distilled food, which you don't have to, frozen food, which you just convert it to whatever you want. So this is one of the best talks I have ever attended, and I have learned so much from this. Thank you once again.
Dr. Ganapathy, I'm humbled. You know, like Jefferson said, you're one of the people who have always been, you know, icons to me. It really makes me super honored, and I'm humbled, and thank you so much, sir.
Wonderful, wonderful. So our time is finished, but I cannot finish the meeting without one last question for Claudia. Claudia, just quickly, what sort of a problem that you see, common problem, that one that you could pinpoint that was common for people who would like to publish papers? Please choose one that you really think it was common from your experience.
I think that my impression is that with more guidance, either from a faculty person or, you know, depending on where the researcher is, or a colleague in the environment that the researcher finds him or herself, I think with more guidance from experienced presenters and publishers, the newer publishers and presenters would do better. I think they don't seek, or they don't know where to seek out guidance from colleagues or people they think are cannot be approached safely. So I think the guidance for newer researchers and publishers is critical. We need more of it.
Okay, wonderful. Yeah. So unfortunately, we have to finish. We almost 7 minutes ahead of our time, and sorry that we have passed now. And I'd like to thank again for Claudia, for Natalia, Professor Ganapathy and Professor Georgi for these wonderful presentations. I thank you all that were with us watching this session of the warm-up of the Global Summit Telemedicine and Digital Health in partnership with the International Society for Telemedicine and e-Health. Please follow us in the internet and please comment to your colleagues that in few days we will have available in the website of the globalsummit.org.br this video. And see you next time. All the best for you. Bye-bye.
Thank you very much.
Thank you. Thank you.